the only European randomized trial, the ERSPC trial, showed a 21% reduction, a relative reduction in prostate deaths in screened population. In absolute terms, that is very little. And this only concerns patients 50 to 69, so not patients older than that. And the problem with prostate cancer is that it's age-related disease, very much. The older a man gets, the higher the probability that he has changes in the prostate that, if picked out by a needle or something else, will show carcinoma. But a lot of those changes will never harm the patient, even without diagnostic procedures, left there as it is, and the patient will live happily on and die with the cancer without knowing that he has one if we do not do diagnostic active procedures in the older age, like men over 70, 75, or even 80 years of age. Well, my view is that if a man is at 80 years of age, he's fit and he has a good quality of life, I would never suggest a PSA test for him, because the probability that he has a positive PSA test is very high. And there's a high probability that he has actually some changes in the prostate that under a microscope of a pathologist will be cancer changes. And that puts him into a risk of over-treatment, treatment that he never benefits from. And by this, he will get nothing else from the diagnostic procedures except harms. The rest of his life is ruined because he's a cancer patient now, and before he was a fit 80-year-old with good life quality, and he would have lived on and died of something else, never knowing that there's a cancer in his prostate. Nothing much, because this is the basic problem in diagnosing prostate carcinoma. We only have PSA test, which is organ-specific test. It's not cancer-specific, first of all, and it cannot separate the good ones from the bad ones, and that's the basic problem, and that's why it's not worth using as a screening test. A biopsy can, of course, show you in some samples Gleason score low, or in some biopsies Gleason score high carcinoma. And also this, you have to remember that within the same prostate you might have different Gleason scores in different spots of the organ. I think that the ERSPC trial protocol and the publication just published states it all pretty well. There's none of the countries actually that were involved in the ERSPC trial, none of those countries recommend population-based PSA screening, and I think that's correct. That's very right indeed. But then there is this problem of individual opportunistic screening, which I would call screening through kitchen door, which is not comparable to population-based screening, because screening in the population is not only the test, it's a whole process. And when we are dealing with an individual and we start extrapolating the data from population-based screening and the reduction of 21% death to this population that we treat individually, I think we're going far out from the real, what the data really says. The relative risk reduction in terms of breast cancer deaths is about the same as in prostate carcinoma screening, pretty much the same. But there are some assets in mammographic screening, and that's due to the fact that the organ is there, it's outside, we can see it, and we can use treatment modalities that are not that radical for this organ, which is not easy when we're dealing with an organ like prostate that is pretty much in the middle of the man in the pelvic region. There is actually a recommendation on national screening up to 69, which is an odd limit in the sense that we have a lot of cancer above 69-year-old. But there's also the same type of a biological effect like in prostate carcinoma too, that once you reach a certain age, the detection of that cancer, it has less effect on your future prognosis, because there are these competing, of course, competing reasons for death or causes of death after like 80 years of age. Population-based screening, no. I don't want it in my country, and I hope nobody does it in their countries. It's causing more harm than good. Individualized, opportunistic screening, okay if a man wants to take a PSA test, if he's worried and so on. After a discussion where you state the risks included in this test, positive test, the risks of overdiagnosis, the risks of overtreatment, and the guy still wants to take the PSA test, it's all right. It's all right to take it, because that's good patient-doctor relationship. Pretty much the same, but the national screening program, I would not stop. It's been on, like in Finland, for example, it's going on for about 30 years. And as I said, it's like established, and also it has these assets of being able to treat with less radical surgery, for example, once detected earlier. Although we should stop selling mammographic screening to women as a modality of reducing breast cancer deaths, because in that the effect is very small.